I'll not tell about the theoretical aspects or the theories, all those things. We'll go with the management directly for the endometriosis. So, one is they have, if you see the RCOG guidelines, SRA guidelines on endometriosis management, it comes with one is laparoscopic management in adolescent girls. So, adolescent endometriosis is one important topic. Then, endometriosis, which is related with or associated with infertility, endometriosis associated with pain. Then, for people who have completed family or whatever it is, if at all we are doing a laparoscopic hysterectomy for endometriosis, okay, these are the broader divisions under which we will discuss the management. We are not discussing about the medical line of management here. Medical line of management is only a temporary management, and lot of people who don't know how to operate, or lot of people who have a faith on medicines would finally end up getting their patients operated. And when they get operated, if at all it is delayed for various reasons, either you give leuprolide injections or whatever it is, generally they will not resolve the symptoms completely. So, whenever we go and operate in a very delayed case, the planes are lost and there is extensive fibrosis, and that fibrosis is very dense, thick adhesion bands would be formed. So, surgery also would be very complex. And then the softness of the uterus becomes soft because of adenomyosis and other factors. So, doing the surgery is also going to be difficult. Okay, so laparoscopy as such is the gold standard for the management of for endometriosis. In per se, even for diagnosis, laparoscopy is a gold standard. Okay, and treatment also gold standard is laparoscopy. Why is it advantageous? Why is laparoscopy advantageous, especially when you are handling a case of endometriosis? Because diagnosis and management both requires microsurgical principles, or the principles of microsurgery can be better adopted by laparoscopic route as compared to an open surgery. Okay, because magnification is good, almost up to 20 times. So even small endometriotic vesicles in the deeper spaces of the pelvis, you can comfortably see on a laparoscope as compared to open. So better access and visualization of the pelvic viscera, and as the pelvis is narrow in a lot of them. Next, since we use microsurgical principles, or our movements are very much controlled, and in laparoscopy everything is slow and steady, in the same way here hemostasis also can be achieved better, because you have multiple electrosurgical equipments through which you can achieve hemostasis. Next, there is very minimal handling of tissues, and hence iatrogenic or post-operative adhesions are also less. Since handling is less, post-op infections are less, pain is less, need for analgesics are less, and the time to get back to work is also very less. And majority of the times we can do much better extensive adhesiolysis by laparoscopy as compared to an open surgery. Okay, though the time it takes to do a laparoscopic endometriosis surgery is a little higher, but still the quality or the outcome of the surgery is much better, and it can even be done as a daycare procedure in a few cases. Only thing you cannot operate by laparoscopic surgery is scar endometriosis. Scar endometriosis, the gold standard treatment is laparotomy only, your conventional open surgery, not the laparoscopic surgery. So when it comes to adolescent endometriosis, when you put in your laparoscope, see basically what happens is there is a delay in diagnosis of endometriosis in adolescent girls, because generally they meet their family doctor or a family physician, or they even see a pediatrician per se, girls between the age of 14, 15, 16 and all. Since the parents are in close contact with a family doctor or a pediatrician, they tend to take their girls to them, and they may not diagnose or they may not have the thought of endometriosis because they feel that endometriosis is not very common in adolescent girls, it's little delayed, but actually not true. It is quite common. The incidence in girls who complain of dysmenorrhea and pelvic pain, and this pelvic pain can be, need not be acyclical, it can be cyclical also. Need not be cyclical, it can be an acyclical pain also. So just because it is dysmenorrhea and cyclical pain, then only you need not suspect. Even if it is an acyclical pain abdomen, you have to suspect endometriosis in adolescent girls. So the incidence can go all the way from 25% to 38.3%. And there are reports of endometriosis prior to menarche also, that is few months prior to menarche itself they have had history of endometriosis or symptoms of endometriosis. Hence high index of suspicion is necessary for diagnosis. The incidence of first degree relative with endometriosis, there is a higher chance of around 6.7%. And infertility and or symptoms and signs of advanced disease can also be seen. So this comes along with young adults. So when you put in a laparoscope, the other thing is, what is the symptom? So the acyclical or cyclic pain is seen in 62% of them. Acyclic pain is seen in almost 1/3 of them, nearing 1/3 of them. And then see, cyclical pain is not that common. See, only 10% of girls do complain of cyclical pain. Then lot of girls even complain of GI symptoms and urinary symptoms. So when they come with those symptoms also, you should suspect adolescent endometriosis, and then you should get a good ultrasonography done. But the problem with this is, even a very good ultrasonologist and a ultrasound machine, you may not be able to pick up the lesions because it may be just peritoneal endometriosis. It need not be a endometrioma. Suppose almost all the therapies have been given, medical line of management has been done, and no proper relief of symptom is there, then only laparoscopy is done. So here, since the girl is an unmarried girl or a very young girl, body build will be very small, abdomen will be small, then tone of the abdominal muscles will be very high, and the fat also will be little less. So putting ports in them is also a challenge because the incidence of complications will go high as the patient is thin, tone is high, okay, and the smaller the size of the abdomen, the entry also is a little challenge. So as much as possible we try to put ports at the umbilicus and then along the pubic line, that is the suprapubic port, so that it is more cosmetic. So what are the lesions that you will see as compared to an adult? So you will see white flame lesions. Then what are these called as? What is this called as? This is the uterosacral ligament. This is Allen-Master defects. So in the peritoneal, there are some peritoneal defects. These are commonly seen in girls who have endometriosis, and adults also you can see Allen-Master defects. Then you will have powdery burn spots. You can have endometriotic spots over the uterosacral ligament, which is the most commonest area. You can see this side involvement is not much, whereas see this side involvement is there, and you see the thickening of the uterosacral ligament here. The uterosacral ligament is thickened here as compared to here, and then you can see even in the pouch of Douglas you have peritoneal lesions. Okay, so red flame lesions are common, powdery burn spots are less. So colorless lesions are also very common, which is more common in adolescent. So powdery burn spots are less, red and clear lesions correlate with pain. Okay, you can see endometriotic nodules or spots over the ovary. You can see them on the rectum. You can see them on the small bowel loop. You can see in the UV fold over the bladder peritoneum. Okay. So when it comes to laparoscopic management, laparoscopy involves in diagnosis, coagulation and ablation of the lesions or resection of the lesions. If no lesions, there is a 3% incidence of microendometriosis that is noted on peritoneal biopsy. So when you do a laparoscopic evaluation, if no lesions are there, suspicious areas like uterosacral ligament, ovarian fossa, these are the areas where primary points where endometriosis will begin. So you take some peritoneal biopsies and 3% you will get to know that they had endometriosis. The goal of the surgery is to relieve the girl of pain, bring the anatomy to normal and eradicate almost all lesions without damage to ovary, tubes, so as to reduce the recurrence rate. Post laparoscopy, preferably better to start them on hormonal therapy, be it only be progesterone is more than sufficient. Progestrogens are more than sufficient to relieve the symptoms. Next is the revised American Fertility Society classification for whether it is mild, moderate, severe endometriosis. So generally this is important only for theoretical aspect. One more thing is the symptomatology of the patient may not always correlate with the severity of the disease. Some may have excessive symptoms, but when we go in and see, the lesions may not be as severe as the patient is telling. Some people will have very extensive severe endometriosis, but symptoms are not that much. So it is individual. Wherever the nerve endings are affected more, wherever entrapment of organs are there, symptoms may be more. So minimal is 1 to 5, mild is 6 to 15, 16 to 40 is moderate and severe is more than 40. Than this, what is important for you is to know whether it is mild disease or severe disease, so that whenever you are planning for treatment, it's very important. Endometriosis lesions, whether they are superficial or deep, whether they are only on the peritoneum, whether they are on the ovary, whether the POD is obliterated. If it is partially obliterated, it's only 4, but if it is completely obliterated, it's 40. So POD is one of the factors which is important. Then there are adhesions also. So adhesions, whether they're flimsy, dense, over the ovary, over the tube, how is it? All those are important factors on deciding the score. Then next, when it comes to management of endometriosis in patients with infertility, do not give hormones for suppression of ovarian function if the woman is come with infertility or subfertility. In minimal to mild endometriosis, operative laparoscopy including adhesiolysis is effective in increasing the conception or live birth rate as compared to just diagnostic laparoscopy. Okay, so basically what this statement means is, suppose you are doing a diagnostic laparoscopy for a woman with either unexplained infertility or for some other pathology, you are doing a laparoscopy. That time you find out that there are endometriotic lesions which are equivalent to mild endometriosis. Don't just come out, okay, you have done a diagnosis and then don't, okay, you have endometriosis, you just don't tell that much and you finish off. Rather, in them, if at all there are adhesions, release the adhesions, and those peritoneal nodules, either you can do a superficial coagulation called fulguration, or you can even excise them. So excision involves use a vasopressin injection needle. Dilute vasopressin is injected just below the peritoneal lesion. So wherever the peritoneal lesion is there, nodule is there, just below 1 to 2 millimeters away, you prick the needle. Subperitoneal, you infiltrate the saline so that peritoneum pops up. Then wherever that peritoneum pops up, just take a scissor and give an incision with the grasper. Catch hold of the peritoneum with a grasper and give an incision and take out that nodule. If you don't want to do all those, you can even do superficial coagulation called fulguration. Infertile women following laparoscopic treatment with either ablation, resection or fulguration. So ablation is generally using Huh? Generally, we prefer to use a bipolar. Okay, ablation is when you are using a laser also. So, laser ablation of endometriosis is the best treatment, but learning curve for it, the laser that is required is highly expensive. So, there is a lot of learning curve, precision is important, or else you may have injuries. Okay, then you can finish at only fulguration of the superficial endometriotic spots, or you can remove it also. Otherwise, if it is in the ovary or salpinx or somewhere, you can just do adhesiolysis. That itself is sufficient. That is salpingo ovariolysis can be done. Then the other one is cystectomy. So if the ovary has a endometriotic cyst, so cystectomy has to be done. So by doing all these things, the pregnancy rates are higher by 7 to 69% in moderate grade endometriosis, and in severe it's around 52 to 68%. In mild, definitely there is an improvement. Even in moderate to severe endometriosis, the pregnancy rates are much higher. Overall pregnancy rates after laparoscopic surgery over 3 years is around 44 to 77 in moderate to severe endometriosis. So basically what we generally tell is, suppose a woman is come with infertility who has endometriotic lesions on scan, what you can do is you can perform the surgery. Just after the surgery, one dose of Lupride or OC pills is sufficient, and then the next month you have to start off the treatment, that is ovulation induction. If it is mild disease to moderate disease and not much of post surgery, everything is okay, no other male factors and other things, you can go ahead from the next month itself with ovulation induction and then timed intercourse. That you can try for 2 to 3 cycles, and then you can even try IUI. So first 6 months is the best time following endometriosis surgery for mild, even few cases of moderate. Suppose it's a severe endometriosis, generally we say 3 months is the cutoff. If it is really bad where the ovarian reserve is less and all, you give suppression for the cycle following the surgery, and then you can plan for IVF straight away, because that gives the best results. Okay, that is very, very important.
Patient with low reserve also, but with endometriosis, suppose mild is there, then also maybe better surgical management or
Again, see, everything depends on the AMH of the patient. If the patient's AMH is low, anything that you energy or whatever that may reduce the ovarian reserve, those things you should avoid. So use of current should be very meticulously used, and then you should know the exact planes of dissection. Try to minimize the handling of the ovary. Okay, so that if at all you are releasing the ovary and ovary starts to bleed, then you will have to use energy. So whatever reserve is there, it is still coming down. If it's a big ovarian cyst, I would still say go aspirate the contents, do fulguration of the cyst wall. Next cycle itself you can induce her off, so that recurrence should be less. If you try to do a cystectomy, so already reduced reserve or borderline reserve, it will go down much more drastically. So that is one thing. So wherever you can, you have to do, you should do it. Only thing is, what is the reserve is the point that is going to decide whether only cystostomy or cystotomy or cystectomy, all those things. Okay. Look for associated factors causing infertility along with endometriosis, like adenomyosis, tubal endometriosis, fibroids. So all those require simultaneous correction. This time one pathology I will treat, next time another pathology, it won't work out like that. So if there is a borderline case of fibroid uterus where it's not a clear cut, you can still go ahead, and whenever you are doing surgery, you try to do a complete surgery, so that the patient, after giving 3 to 4 cycles, when all the factors have been ruled out, then you do a myomectomy, which may be the cause, all those things won't work. Because you are doing the surgery, you will finish off the whole thing. That gives the best results for the patient. So what are the principles of surgery? When it comes to principles of surgery by laparoscopy, adhesiolysis, so that tubo-ovarian anatomy, uterine anatomy is maintained to the best possible way or achieved to the best possible way. Then release the ovaries from POD and ovarian fossa for easy oocyte pickup. Laparoscopic CO2 laser ablation has shown better results than bipolar fulguration for endometriotic lesions, as the depth of tissue damage is very less. Okay. Laparoscopic ovarian cystectomy has shown higher pregnancy rates than just cystostomy. That is, just go drain the chocolate material and then fulgurate the wall and come out. So that gives very less, relatively less results as compared to the cystectomy. But you are going to do a cystectomy completely only if the reserve is normal. You cannot do total cystectomy if the reserve is less. So whatever exophytic cyst wall is there, you excise off. Wherever it is stuck to the base of the ovary or the hilum of the ovary, where the blood vessel is coming from the IP ligament, there you need not touch. There you don't do forceful cystectomy, because once it starts to bleed, you go and fulgurate. That is where the damage to the ovary is. Decision for cystectomy depends on the AMH levels, as it is associated with loss of ovarian follicles during peeling, that is cystectomy. Use of adhesion prevention barrier like interseed is helpful. Next, when it comes to endometriotic ovarian cysts, mode of treatment is either drainage, cystostomy with fulguration, or it can be cystectomy. So I have told drainage when it's a very small one where you cannot even peel. So majority of the times it's a peritoneal collection basically. When you release the ovary itself, you can see chocolate material coming out. That means between the peritoneum and the ovary, the cyst is developing, and as you release the ovary, the cyst opens up. So those you need not do anything, you just give a wash and aspirate the contents. If it is cystostomy with fulguration, as I said, if it is stuck at few places and the AMH is on a borderline level, try to take out how much ever possible, or the portion of the cyst wall which is easily peelable and it is not attached to the hilum or anything. Those places you leave behind where it is attached. Okay, that then what you do is, whatever portion of the cyst wall is left behind, you superficial coagulation with bipolar energy, so that the cyst doesn't reform sooner. When you fulgurate it, the possibility of it reforming is very less. When do you do cystectomy? When AMH is good, not related to infertility, in such cases also, to reduce the incidence. So, what is the criteria to start to do a laparoscopic surgery? So, when the size is larger than 3 centimeters. So, a woman comes to you with infertility who is having an endometriotic cyst of 4 centimeters. So, you can still wait, or you want to do a laparoscopic procedure. If it is 3 centimeters, you want to wait or do a laparoscopic procedure. 3. Okay. 4.
Until and disaster, any like oocyte aspiration, any problem is there, that time only we do cystectomy, or that is not.
You will do laparoscopy or not? You don't do laparoscopy. More than 3 centimeters, they say. See, again there is a dilemma here, and infertility specialist doesn't want to do a laparoscopic procedure until her IVF failed or anything like that, or IUI is failed, or coexisting pathologies are not there. Suppose you don't do a HSG or anything, you will not get to know the tubal pathology, whether no matter, even if you do a HSG and the tube is patent, What if the tubo-ovarian anatomical relationship is altered? Ovary somewhere stuck in the POD and the tube is stuck to the lateral pelvic wall. Even if ovulation happens, it will not be able to pick it up. So those are the things which you will have to take a call on case per case basis, because guidelines can just give you a cutoff beyond which you should do, below this you need not do. But as such, when you analyze, when you do the scanning, you will get to know whether the sliding test is positive or not. If there are pelvic adhesions, when you do a transvaginal sonography sliding test and all, if there are adhesions, prefer to do it, because tubo-ovarian anatomy can be restored. When it comes to management of the cyst in that patient, you don't do a extensive cystectomy and all. Just go aspirate the content, release the ovary from the fossa. That itself will be sufficient enough. Not that when you do a laparoscopy, every patient you take out the cyst wall and other things. Whereas some laparoscopic surgeons, be it a gynecologist or a general surgeon, what they tend to do is they tend to do the laparoscopic procedure much faster, or as the first line of treatment as compared to ovulation induction or directly going with IVF. So there should always be a discussion between the infertility specialist and the endoscopic surgeon, so that justice is done to the patient. Before you do the surgery, AMH is mandatory, or else then the patient should not blame, or the other doctor to whom the patient goes and asks for an opinion, oh, this low AMH is because of the surgery. They shouldn't be blaming you, which can happen. So as much as possible, you don't make any statement to the patient or patient's relatives that may feel that they may feel that no, the first surgery was not done properly, that is why AMH is down. So you are not giving any possibility of the disease per se to cause low AMH. Disease per se will cause low AMH. That to become very low, your surgery may be the reason, that's it. So pathology itself is such that it can reduce the AMH. It is not always dependent on the surgery, but again the experience of the surgeon, how he does the surgery, all those matters. Why I said that was, guideline says if it is more than 3 centimeter, if the ovarian cyst is actually interfering or coming in the way of your oocyte pickup once you induce the patient, in those cases you have to do laparoscopic procedure. But anybody who has a cyst size, okay, a patient has 3 cysts, all the 3 are 2 centimeters, 2 centimeters, 2 centimeters. She has 3 cysts on one ovary, 1.5 to 2 centimeter, 1.5 to 2 centimeter. So if you keep adding, it is almost like 5-6 centimeters. So again, these are all the things which you should think and take a decision case per case basis, because finally what we want that patient to conceive sooner. Whether that conception will happen following ovulation induction or your IVF, or following laparoscopic procedure and then induction, it has to be decided. Laparoscopic surgery for deep infiltrating rectovaginal endometriosis has not shown any increased rate in the pregnancy following surgery. But the thing is, what if the woman has so severe dyspareunia that she is not able to have sexual intercourse at all, so that how can she have a conception chance? If the patient has a deep rectovaginal nodule or a vaginal nodule causing severe dyspareunia, they would avoid it. So the chance of them having a natural pregnancy is only very less. So in those patients also, if at all you reduce the pain by doing a surgery, then probably they may try naturally, or you can do an IUI or something, and then they may conceive. So just one statement from one guideline will not make it a dictum that okay, this is like this, I will not. So you have to take a call on each case basis. Laparoscopic management of endometriosis when it is associated with pain. Here the main thing is reduction of the disease burden, like malignancy. When you do the primary surgery, reduction surgery, that means how much ever you can remove the endometriotic lesion, that much you remove. That is what is to be done for pain also. So laparoscopic surgical treatment is effective in endometriosis associated with pain as compared to diagnostic laparoscopy. That may include even a simple fulguration also, or releasing a simple adhesion band. That itself may relieve the symptoms for the patient. So that is one. Next thing is laparoscopic ablation and excision are equally effective in reducing pain, but excision has better advantage of having a specimen for biopsy. Suppose patient has endometriotic spots on the peritoneal surface, you go and fulgurate it, then you won't have any specimen for biopsy. Though it appears like endometriosis, but definitive diagnosis is by biopsy. So when you excise it, you will have a specimen for biopsy also. So technique of excision, I have told you, infiltrate dilute vasopressin below the endometriotic lesion to form a subperitoneal bleb, and then that bleb can be held with a Maryland or a tooth grasper and just excise it off. It's like you have this carpet here, just take a needle, inject just below this carpet so that the carpet rises up, and then you take a grasper and cut off that area wherever it is. This is helpful because if you have the peritoneal lesion, here is the peritoneal lesion and just below that is the ureter. If the ureter is right below it and it is stuck to it, you go and fulgurate, the thermal damage spreads to the ureter. So lateral thermal damage. That can be reduced. What you can do, just lift the peritoneum wherever the lesion is, infiltrate with either plain saline or dilute vasopressin saline. That will create a bleb. Just excise that bleb. That is more than enough. You are not causing any thermal damage to the ureter, and you will have a specimen for biopsy. The bleb increases the distance from underlying vital structures like bladder, ureter, or the bowel loop. So what is the goal of the surgery in these patients with pain associated with pain in endometriosis? Reduce the burden of disease. That means excise or ablate all the lesions so that recurrence rates are reduced. Next, delineate the course of the ureter at the beginning and at the end of surgery if at all you have not done ureterolysis. If you have done ureterolysis, it is always under your vision. If you have not done ureterolysis, that is, if you have not done any dissection in the subperitoneal level or the retroperitoneal level, you have to delineate the course right from the beginning and you can avoid those areas. Adhesiolysis has to be done to reduce pain due to entrapment of nerves in the adhesion. So peritoneal lesions, all those will actually be sitting on the nerve endings. Subperitoneal space is the area where the nerve endings are. So this endometriotic lesions will be causing irritation and then causing pain. So that you can take it out. Restore the anatomy back to normal as much as possible. Perform additional procedures like laparoscopic uterosacral nerve ablation or presacral neurectomy for reduction of midline pelvic pain. Okay, see, Luna was one of the procedures which were commonly done quite some time back. Today, it's not very widely used or performed. One of the reasons is the pain is very short-lived. Second thing is, how do you do a laparoscopic uterine nerve ablation? Anybody has seen? Any idea? So basically, uterine nerve is there along the medial half of the uterosacral ligament. So what they say, just half to 1 centimeter away from where the uterosacral ligament is attaching to the uterus. So this is the uterus, this is where the uterosacral ligament is. So just from the place where it is getting attached 1 centimeter or below, there cut the medial half of the uterosacral ligament which contains the nerve endings, so that which has the nerve, so that will reduce the pain. The drawbacks are, if you cut the entire thickness of the uterosacral ligament, prolapse chances are very high. Then if you go a little lateral, you have the ureter. So all those things are there, and pain is not very short-lived. Some people do a presacral neurectomy. Again, that is in the space between the bifurcation of the iliac vessels. Common iliac, you have the aorta getting bifurcated to common iliacs, no? In between that triangle is the place where you have the presacral nerve roots. So that inferior hypogastric plexus, all those are there. Those presacral nerve roots have to be removed for your pain. But the problem with that is they may have constipation, then they may have bladder symptoms also, few of them. So bowel disturbances can be there. All those we should explain it to the patient. Then the other thing is the pain relief is only short lived. Next, when it comes to endometrioma, cystectomy is preferred over drainage, and ablation, as it reduces pain in a much better way, and reduced recurrence rates are also seen. When it comes to deep infiltrating endometriosis, laparoscopic surgery consists of excision of nodules, that is deep infiltrating DIE nodule, which is there in the rectovaginal septum. Okay, and in the uterosacral ligament, either you will have to remove them. Along with that, if the rectovaginal nodule is actually infiltrating only the serosa of the rectum, then you have to do shaving. If it is seromuscular, again you have to do an excision, discoid excision, and then closure of the rectum. If at all that lesion has gone into the mucosa of the rectum, then treatment is resection anastomosis. This generally is one of the high-end surgeries where you will have to involve a gastrosurgeon also, where circular staplers are put. So circular staplers are put through a equipment or a stapler firing equipment per rectally. So you have to dissect the entire rectum completely from the sides, and then a portion of the rectum where the lesion is has to be identified and dissected slightly above, so that the normal margin of the rectum should get anastomosed with the normal margin in the proximal and the distal ends. Then you introduce per rectally this circular stapler machine, and then there is a circular ring which is called an anvil. The anvil will be pushed up, so whatever the size of the lesion is will come in between the two rings of the thing, and then when you fire the stapler, there is a circular ring here and there is a circular ring. This will go and stick to this. So whatever portion is there will be inside. So once you take out the stapler, you get the specimen in that. It's like a tubular thing. You cut it, whatever remaining adjacent things are there, that will be fixed.
Laparoscopic guidance.
Yeah, everything is under laparoscopic guidance. But see, you have the linear stapler and the circular stapler. Linear stapler is like a straight one thing. So what you do, you apply one stapler here. If the lesion is here, then below one more, and then you bring the two of them closer to each other, create an opening between the two, and then anastomose it, which is more complicated for a rectal lesion to re-anastomose. So rather, for those situations, you have a circular stapler which you can introduce anally. Per rectally you can introduce, and that goes and does the cutting and then anastomosis also. Okay. When it comes to nodules over the bladder itself, if it is only the bladder serosa, you can just excise laparoscopically and do a cystoscopy. If there is no involvement of the muscularis and the mucosa, you can leave behind. If the endometriotic lesion has reached the mucosa of the bladder itself, urinary bladder, what you do is first you go and do a cystoscopy. See where exactly is it in relation to trigones. If it is very close to the trigone or in the lateral margins, then what you do is you do a ureteric stenting first itself. Then go laparoscopically, then release the UV fold of peritoneum, identify the portion where the bladder is, nodule is, then give a wedge excision of that nodule, and then suture the bladder in 1 or 2 layers depending on the size of the defect. So for that you can use a V-lock also. Okay. Bladder endometriosis includes excision of lesion and primary closure in 2 layers. When it comes to ureteric endometriosis, the lesions can be excised after stenting, or after you can even do a segmental resection and reimplantation can be done. Suppose the endometriotic lesion is actually kinking the ureter, not from external, from an internal. That means the endometriotic lesion has entered into the mucosa and muscularis level of the ureter. That ureter is damaged. So in those situations you will have to resect that portion and then either reimplant the ureter to the bladder, or you may have to do a Bowery flap so that you get a better length if at all your ureter you are not able to dissect it and bring it to the bladder, because it should be a tension free anastomosis. So when it comes to hysterectomy, laparoscopic hysterectomy with oophorectomy is what is preferred. Whenever you are doing for endometriosis, even if the woman is younger, if it is with endometriotic cyst, better to remove of the ovary also in them, because the risk of recurrence of with cyst is high, and when they come back with cyst following hysterectomy, adhesions are very high. So in that situation, doing a ovarectomy or a oophorectomy is very challenging. Hysterectomy without oophorectomy has shown 6-fold increase in the development of recurrent pain and 8-fold increase in risk of resurgery. So who would like to undergo another surgery? When you know the pathology is making them prone for a surgery, then better to take out all those things. So challenges that you face during hysterectomy are dense bowel adhesions, bladder adhesions, ureteric adhesions, altered anatomy, increased vascularity everywhere, so it starts to bleed, and then the ovary is adherent to the POD and to the ovarian fossa, and it is stuck. So releasing them is a challenge. Along with that, uterus may itself have adenomyosis, adenomyoma, fibroids, and then you have the risk of obliterated POD. So this is one situation where I was showing you that uterine artery ligation at origin, dissecting the ureter right at the beginning itself, bringing the ureter away from your operative field. So that will reduce the incidence of ureteric injuries, because what happens is the ureter anatomy is altered. So since the anatomy is altered, you have the uterine artery coming here like this and then bifurcating into ascending and then descending, and the ureter is going like this. This ureter, because of adhesion, will get medialized towards the uterus itself. Though you are staying very close to the uterus and coagulating, hugging to the uterus, you still can land up with ureteric injuries, because you may not have directly held the ureter at all, but the lateral thermal damage can spread almost 1 centimeter to 2 centimeters, which can cause ureteric injury. So in that situation, again the thing is, stenting may be required. Stenting may not be sufficient to relieve the symptoms or be as a treatment modality. So you may have to resect the ureter, and all those things may be required. So better is you do ureterolysis right from the beginning, dissect it out, and there are people who do extensively only these kind of surgeries. So there are pelvic surgeons who do extensively endometriosis, because surgery for endometriosis is much difficult as compared to surgery for an oncological case. Gynec oncology like CA cervix, CA endometrium and all is not that difficult as compared to a difficult or some cases of endometriosis, because the tissues are not the same as they behave in non-endometriosis patients. Since the endopelvic fascia, there is lot of inflammation that is happening in the endopelvic fascia. The fibers are very firm to hard. The tissues are firm to hard. So dissecting them also is a challenge. Vascularity is high, and the adhesions are those which are very fibrous in nature. So it generally will be a dense adhesion. So releasing them is a challenge. Role of cystoscopy in such cases is following surgery for complex endometriotic disease, visualization of the ureteric peristalsis by laparoscopy for ruling out ureteric injuries, followed by a cystoscopic evaluation for efflux of urine through both ureteric orifice is a good practice. Cystoscopy alone may not be sufficient to rule out ureteric injuries. So, a ureteroscopy helps in actual detection of ureteric injuries. A greater index of suspicion for ureteric injuries helps in early detection and prevention of complications. Some surgeons prefer to do ureterolysis at the beginning of surgery to avoid inadvertent damage. So, when you have a case of severe endometriosis, do you want to stent the woman prior to doing surgery, or you don't want to stent the woman? How is it? Prior to surgery itself. Everyone? Prior to. What if I say no?
MRI
Cystoscopy will not make any difference. Cystoscopy will just tell the status of the bladder.
MRI has to show some ureteric involvement, then we'll start.
Okay, only if MRI is showing ureteric involvement. You are dependent on the radiologist. Okay, then.
You can keep the urologist as standby in case post opening if it is not.
Only if it opens, then you will stent.
Just doing diagnostic, you may feel that it's too close to the ureter.
You will not do any diagnostic procedure for severe endometriosis. You have to do an operative procedure for
First
endometriosis.
we visualize and if we feel that there is
She is for hysterectomy. You want to, as soon as she is induced, you want to stent and then do hysterectomy, or you want to do hysterectomy only if you have doubts you want to stent.
Because if it is dense endometriosis, already so much adhesions is there, chances of injuring the ureter is more.
starting with the
So at the start only will be easy. Later stenting is difficult.
Later, already resection will happen.
I would say I don't want to stent in the beginning. Why? If I am saying that, why?
chances of
We can do dissection properly so that ureter will be away and we can finish the surgery.
So once you stent the ureter, they become rigid. Once you stent the ureter, they are rigid. So lateralization won't happen. They tend to come medially again. They tend to come medially.
Before the uterine after dissection.
Oh, half you will do hysterectomy, you will call the urologist to stent, and then you will continue. Good. So as much as possible, we don't like to stent the ureter before doing hysterectomy.
So until unless some if kinking and all ureter
Even if kinking is there, it's okay. You have to release the adhesions to release the kink. That kink,
And it's suppose ureteric endometriosis is there.
Uh-huh.
That time
at that time, what did I say?
ureter is involved.
Use,
to
you have to dissect the ureter, excise the portion of the ureter which is affected, then you need to stent the ureter, and then you need to do a reimplantation. That's it. So for reimplantation, you will give a nick on the bladder, you pass a stent through the ureter through the bladder, and then that along the stent in place, you will suture the ureter to the bladder. Okay, only then, not before. Okay, so basically some surgeons prefer to do ureterolysis at the beginning of surgery is the one which everyone should do. Since people don't have either experience or knowledge or skill to do it, they try to do half-hearted surgery, and then at the end of surgery, then you will realize, oh, is the ureter injured or not? You keep your fingers crossed for next 21 days. That should not happen. Rather, you go start dissect the ureter, ureterolysis. So once you dissect the ureter and keep it away, then you can boldly do the surgery medial to the ureter. Even if you are doing a what do you say, not a hysterectomy, you are doing a uterine preserving and pelvic preserving surgery also, a ureterolysis will make the surgeon more confident to do the procedure properly. Or else you will feel like, okay, if I pull the ovary now, if it starts to bleed, I have to coagulate in the ovarian fossa, ureter is there in the ovary. Either you will do substandard quality work, or you will not do anything, you will just suck out the contents and come out. That should not happen because recurrence will be high. Second thing is, if that entrapment or the adhesion of the ovary itself is causing pain to the patient, sometimes patients will tell, I have a deep pelvic pain which is more on one side. So when you do a scan, you know that the ovary is stuck on that side, and when you do laparoscopy, you can see the ovary stuck in that on that side. Then if you don't release it, then what's the point of doing the surgery? There is one 3 centimeter cyst, you will go aspirate the cyst, take out the wall and come out. That should not solve. That should not be done, because that will not solve her symptoms completely. Okay. Second thing is here, this is also very important. Cystoscopy alone may not be sufficient to rule out ureteric injuries. What does that mean? Suppose I have done a hysterectomy, I am having suspicion of ureteric injury. So what do? I will tell, okay, take a hysteroscope, we will do a cystoscopy. So I go and do a cystoscopy. There is no bladder injury, nothing. You can see urine coming out of ureteric orifice. So are you happy with that? Delayed thermal injuries are there. So if you go one step ahead, okay, you have a ureteroscope, you go in and see ureter, but even then you may not be able to pick up the area of vascular injury, because slowly tissue necrosis develops. Necrosis may take almost up to 3 to 7 days time, and then the symptoms may start appearing after a week also. Rarely it can happen even after 21 days, even up to 21 days. Not common, but very rarely. So always just doing these things will not satisfy anything. It is just our self-satisfaction. Oh, I have done a cystoscopy, urine is there, medico-legally I am still okay, because I had that suspicion. You should have at least a little bit of, there should be an index of suspicion. Then only you can tell the patient, see, it was a very difficult case. I had suspicion whether the ureter may be involved or the bladder may be, so I have done a cystoscopy. As of now, everything looks normal. If you tell that, patient also will have relatives, they will also get a feeling that no, case was difficult, the doctor has tried to do the best possible with them. Rest is left to what will happen over a period of next 2 to 3 weeks. But if you have not told anything, you don't have a suspicion at all. When the patient comes to you with, what are the symptoms they'll come with? Severe pain may not be there. Okay, fever. Then how do you want to, if you do a video call to the patient every day, first post-op day, second post-op day, like that till 10 to 14 days from surgery, what do you want to see in your patient? Yes, patient's general condition, it should improve. That means pain should come down, analgesic requirements are less, her general condition as such only will be better, and all these things will be in a progressive way. If that doesn't happen, if patient has vague pain not reduced with anything, if she has leak, vaginal leak or anything, then all these things should start giving a hint. Abdomen, again, slowly there is irritation of abdomen, so they will have guarding, rigidity when it becomes a full-fledged. So all those things you should have in mind, and when you have a suspicion, then only you will be able to pick up at a sooner or earlier stage. If you don't have suspicion, then nothing. Okay, that is important. So laparoscopy is the gold standard because it involves a lot of microsurgical principles of surgery can be applied. Okay, First surgery is the best surgery. You cannot keep putting the woman under your knife multiple times. And even if you put them under your knife, if you are doing a half-hearted job or a incomplete job, then no point. You are going to make the surgery more and more difficult. The case also will become more and more difficult, or the more complex it will become. In infertile women, decision for cystectomy should be made after assessing the ovarian reserve. So preferably do a AMH levels before itself to tell the patient, okay, this is the situation, so I'll do this surgery. That is how, if you counsel, they'll also have more confidence. They'll understand why you are telling, why this blood test is required. Okay. The chance of endometrioid carcinoma should be kept in mind when dealing with large sizes. These are very rare, but still you never know. So if there is a solid papillary lesion inside the endometriotic cyst, then you should always suspect malignancy also.